So I'm Dr. Janieca. I am a pediatrician who's working in a 30-bedded SNCU in a district hospital in Shillong in Meghalaya. So
would you mind turning the video on so that we can see you also?
Actually, my internet is not very stable, so that's
no
why
worries. You can continue with audio. Yeah.
On it and see. I don't know if it's okay. Yeah.
We can see you actually. Yeah.
Yes. Okay. Yeah. So the topic of my presentation today is tips to improve CPAP success and reduce complications. So before we go into the topic, I want to discuss about some of the complications of CPAP. So as we have even seen in the earlier case also, pneumothorax. Okay, so even though that was not a complication of CPAP, but pneumothorax is one complication of CPAP which can occur. It usually occurs in acute phase. It is not a very common complication of CPAP. It results from underlying disease process and not positive pressure alone. CPAP levels more than 8 centimeters of water increases the incidence of air leaks. CPAP can also cause cardiovascular complications. High CPAP leads to an increase in the intrathoracic pressure, which decreases the venous return and ultimately decreases the cardiac output. CPAP also decreases pulmonary blood flow with increased pulmonary vascular resistance. Optimizing CPAP level and maintaining adequate intravascular volume is the key to prevent complications, cardiovascular complications due to CPAP. So gastrointestinal complication in the form of gastric distension is a very common complication of CPAP. Gastric distension leads to splinting of diaphragm, and this causes respiratory compromise. CPAP also causes a decrease in the gastrointestinal blood flow. In renal complications, CPAP decreases renal blood flow, decreases GFR, and reduces urine output. So in both gastrointestinal as well as renal complication, again, optimizing CPAP level and maintaining adequate intravascular volume is the key to prevent complications due to CPAP. Local complications are the complications that we should be wary about because these are more common with CPAP. Complications such as nasal irritation, damage to nasal septa, skin damage, nasal bleeding, and columnar necrosis are the common local complications of CPAP. When we talk about causes of CPAP failure, I have categorized them into two groups. One is the clinical conditions which cause CPAP failure, and the other is the device-related conditions. Among the clinical conditions, babies who are born with very low or extremely low birth rate are more prone to CPAP failure. Initiation of CPAP is very important at the right time because delay in initiating CPAP can be an important cause of CPAP failure. In case of babies with very severe RDS, CPAP may not be the ideal primary mode of intervention because CPAP failure is very common in this group of babies. Babies who have association with other comorbidities like sepsis and hypertension also have an increased rate of CPAP failure in them. And other causes of CPAP failure may include recurrent apnea and progressive metabolic acidosis. Now, when we are putting babies on CPAP, we have to be very careful with the devices, in monitoring the devices and assessing the devices regularly because CPAP failure due to device is also common. So some of the causes include improper fixation of CPAP device, frequent dislodgement, excessive secretions obstructing the airway of prongs, low flow rates in the circuit, and faulty machines. So as we have discussed earlier that the local complications are more common because of CPAP. So it is very important how we choose, like the choice of nasal prongs, the size of nasal prongs, the fixation of nasal prongs, and assessment and monitoring of the interface regularly. So the CPAP prongs and the nasal interfaces, they come in various sizes according to the weight of the body. So it is very important that we choose the correct size. The correct size prongs should snugly fit the nares without pinching the septum or causing blanching. We often use a moustache while we are placing the nasal interface. So the moustache in the nasal cannula should never touch the septum. When a CPAP interface is fixed properly, the whole interface moves together when the baby moves its head. So we should ensure that in this way, the fixation is proper. As we all know that the newborn skin is very sensitive and is prone to injury. So in order to protect the newborn skin, a tegaderm or a duoderm base may be applied. It is very important that we care vigilantly so as to ensure a minimum of 2 millimeter space is always there between the prongs and the septum. As we have discussed earlier that the skin is very sensitive in the newborn, so frequent monitoring for skin color, perfusion, blanching, crusting or excoriation needs to be done. Suctioning should be done every 3 to 4 hours, and whenever we are doing suctioning, we can also massage the nasal septal area and the area around it so that the blood circulation is maintained properly in that area. So whenever a baby is put on CPAP, as far as possible, we do not handle the baby frequently. We ensure that the baby is allowed to rest as much as possible. And when we are giving care to the baby on CPAP, it should be a cue-based care. So CPAP a baby on CPAP can be put in different positions: left lateral, right lateral, supine, prone. But we should make sure that we change the position of the infants every 3 to 6 hours. And also make sure that every time we change the position of the baby, we always support the airway using a neck roll. Whenever the baby is put in a prone position, a firm chest pad should be put under the baby. And it is very important that the skin should be checked frequently for sores. It's very important for proper CPAP, for CPAP success and to reduce complications, that the airway is maintained patent during all times. So suctioning of the mouth, nose and nasopharynx has to be done every 3 to 4 hours or whenever required. While we are performing suctioning, the infant's eyes should be covered with the dry cloth so as to protect the eyes from getting contaminated by the secretions of the nasal and the oral cavity. And when we choose the suction, the largest size catheter that is able to pass into the nasopharynx without significant resistance should be used, so that the thick secretions can be suctioned with ease. Then 0.9% saline solution can be instilled. This helps in lubricating the catheter and loosening the dry secretions while we are suctioning. Patency of the prongs should be tested at least once a day. So as we have discussed earlier, that gastric distension is a very common complication of CPAP. So to avoid this, an orogastric tube should be placed with its end open to allow gastric venting and decompression. The tube should be gently suctioned every 3 to 4 hours in those babies who are NPO. And in those babies who are getting feeds, before every feed, the gentle suctioning should be done. Okay, so like we were talking about the device failure. So in order to prevent device failure, it is very important that we frequently and systematically assess the CPAP delivery system. Sterile water or 0.25% acetic acid can be used as the liquid in the bubble chamber. It is very important that we ensure that in the bubbling chamber, the gas is always bubbling, so this has to be monitored regularly. The inhaled gases should be well humidified with temperature 37 degrees Celsius so as to prevent drying of the respiratory mucosa and all the complications associated with it. Condensed water in the circuit should be periodically drained. The distal end of the expiratory tube should be inserted to appropriate depth at all times. Nasal CPAP circuit should be changed once a week. So as we all know that feeding is not a contraindication in babies who receive CPAP. So early feeds need to be started in the form of trophic feeding with orogastric tube once the baby is hemodynamically stable. And these feeds can be increased gradually depending on the infant's clinical status. All of us are aware of the short-term as well as long-term benefits of kangaroo mother care and how how it improves the outcome in a baby who is cared in the NICU. So KMC should be started and encouraged while the baby is on nasal CPAP and stable. Other aspects of developmental supportive care such as nesting, swaddling, containment, promoting day and night cycling of nights, minimizing sound levels, involving parents in nursing care should be practiced vigorously and encouraged in babies who are receiving CPAP. So we have discussed earlier why the optimum level of CPAP is very, very important in reducing complications. So we can determine the adequacy of CPAP by following ways. The baby should be comfortable while on CPAP, should have minimal or no retractions. CRT and the blood pressure in the baby should be normal, and the baby should maintain normal SpO2. One way of determining the adequacy of CPAP is by performing a chest X-ray. On optimal settings, number of posterior intercostal spaces above the diaphragm should be 7 to 8. If lungs are low volume, then we increase the CPAP, and if hyperinflated, then decrease the CPAP. So these are some of the criteria that we use for weaning of CPAP. CPAP can be weaned in a baby more than 30 weeks post-menstrual age. If the baby, there is no supplemental oxygen requirement for at least 48 hours. If the baby who is having PDS asymptomatic, there is no apneic episodes, is free of infection, there is no significant bradycardia or oxygen desaturation requiring intervention, less than or 2 self-limiting bradycardia or oxygen desaturation episodes in the last 12 hours. So these are the criteria for weaning on CPAP. So, and last but not the least, infection control is one of the most important factors so as to ensure that CPAP success and reduce complications. Hand hygiene should be strictly followed. We should minimize as far as possible the number of pricks. Then early feeding with mother's own milk or human donor milk is important for preventing infections. reduce duration of IVF, IV access, lines, tubes, and catheters. KMC is an important factor which prevents infection in the newborns. And disposable nasal CPAP kits should be used and should be changed after appropriate time. Thank you.
Fantastic. This was one of the most comprehensive talk on CPAP. I think you've covered all aspects of your proper neonatal care. Very good. I think this presentation can go as a guideline for management of CPAP. So, I mean, it's always the right baby, right device, right interface, and right care of nursing, which makes the CPAP success better and better. So, I think it's all nursing driven, and you have so nicely covered everything. Let's go. Yeah, great job. Seriously, I mean, I have nothing else to add. Maybe some pictorials would have been good to show, but one of the question, Payal, Dr.
Kiran, just 1 second. Sorry, before you start the discussion, can I make a quick comment?
Yes.
Yeah, so I totally agree with you. Amazing presentation, Dr. Janieca. As I said in the group, I mean, we have 3 very good presentations today, and we are looking forward to the next one, but very well done. And obviously, congratulations on covering all the aspects, including developmental care and the weaning techniques. Of course, I mean, the X-ray part is not essential. If you monitor clinically and going with recessions and work of breathing, it's adequate. And same with blood gases. I mean, the timing, you don't need many blood gases on the CPAP. And the part I would like to stress from the presentation is the suction part. I mean, the nasal injury is very common in the very tiny babies. If you manage the extreme premature babies, we often struggle with nasal patency, and without the nasal patency, non-invasive doesn't work. I think Sanchita was the one presenting in our PCS, and the same discussion happened. But in terms of suction catheter, I mean, the largest one that will easily go through, you mentioned, but use the smallest one possible as well at the same time. Because the larger the bore, the more likely to injure, and the direction of the insertion, the nursing staff should be very aware that they don't insert it towards the septum, and also they don't injure the tissue. They don't and use the suction only while withdrawing. So the saline you mentioned, and not to do unnecessarily you mentioned. So just to add this point, that in the bigger babies it's not a big issue, but in the smaller babies, especially, these are the ones where it's challenging to maintain them, and the nasal injury, bleeding, obstruction, this may cause NIV failure in these babies as well. So again, excellent presentation. Kiran, over to you. Thank you.
Sure. Totally agree with the comments. I think it's again, so it's always the art of giving CPAP, rather than science. How better you can do with your nurses. So starting from the right, covering the nose with the, you come feel, and you already mentioned you're doing like a mustache and all those seal, how you can protect the skin around it, and nicely you can create the apertures. I think that all is very important. And again, even the directions, how the canula, the nasal prongs are going, sometimes they get pulled. All those things, nurses, we should teach the nurses to watch sometime, with the change in baby's position, how comfortable the baby is. Again, difference between prongs and CPAP mask. So sometimes some units practice changing between mask and prongs, because mask can cause the nasal bridge injury, and prongs can cause the columella or the septal injury. So both has got its own risk. So sometimes you can even alternate between mask and prongs. And if babies are stable, always good time to give some time off when you're doing cares, some time off so that the circulation again improves. And you mentioned all that. Now, one question which is Dr. Payal has asked, does NG suction is recommended? Yeah. So you want to ask something, Dr. Payal? No, you unmute. Yeah.
Yeah. So this is the question. Does it recommended to do NG suction or OG suction on CPAP?
No. So suction is probably not required. What you can do is something called as venting. So now if you are on too early feeds, many times if you feed it, then sometime you have to keep the feed clamped. But then after that, you might be able to vent it. So especially if you're getting a CPAP belly, you can actually raise the end of the NG tube and maybe connect it to a syringe. There are different units have different ways of venting the tube. So just venting and letting the air out is enough. no need of suction, because suctioning then you might just remove the milk might come out, or you might cause some mucosal injury. So you have to be careful using suctions for the NG. Just venting is good enough. Again, there prone positioning, keeping babies prone helps to reduce the gastric distension. One more thing helping gastric distension is use of variable CPAPs. Like devices like SLE and all, some devices have got variable sort of flow CPAP. So if you're having troubles with abdominal distension, you can, if you have a device which can give you variable flow CPAP. So there, the many times when the seal is adequate, you require less flow to generate the same amount of PEEP. And only when there is a leak, the flow will automatically increase, and that actually helps for abdominal distension. So there are a few things you can do, but no need of suctioning. I don't think anyone tries doing suctioning for that. Next question, Dr. Avneet is saying, I hope you're happy, Dr. Payal. Yeah.
Yes, sir. Thank you, sir.
Okay. Kindly guide me how much flow to be kept on CPAP, how to decide. So, okay, maybe Dr. Jacinta, you want to answer that? That's your topic.
So it's okay, sir. You can answer it, sir.
Yeah, so again, I just mentioned, so generally 8 to 10 liters is what most of the machines will decide. Now, if you're giving ventilator CPAP, you don't really decide the flow. So the machine will decide how much flow is to be required. So if you have different types of, like, if you have a bubble CPAP or a flow driven CPAP or a biphasic CPAP, but 8 to 10 liters is generally good. 8 liter is probably optimum. Sometimes 6 to 8 liter, if you keep it on lower side, you may not get enough PEEP, especially when you're trying to reach PEEP of 6 or 7. You might need to increase the flow. And then if you have a variable flow CPAP, again there the machine will decide how much exactly the flow is required. So it ranges again from anything between 5 to 6 up to 8 to 10. So that's kind of a range generally is recommended for the CPAP. So flow is decided based on the desired PEEP you want to achieve, and most of the machine will give you PEEP. Most of the modern devices digitally will tell you how much is the delivered PEEP. And before going to increase the flow, try to make sure your seal is correct, your cannula is correct. Sometimes the mouth is open and the PEEP is lost. So you can actually even use chin straps, which help you to close the mouth, and then your PEEP will go up. So increasing the flow probably is the last thing I would do, because it will cause inadvertent gastric distension. Try to do the basics right. Make sure the seal is correct. Make sure sometimes the mouth is closed. Sometimes even you can use dummies. Put like a dummy in the mouth so that the baby sucks and the seal is better. Or as I said, some chin straps needs to be used. But be careful with those chin straps, because if they are too tight, they can actually injure your the facial nerve or this thing coming out here. And we had seen some nerve injury with those very tight CPAP or the chin straps or some of the tight interfaces. So be careful with that. Next question from Marcia. How many minutes after feeds do you open the nasogastric? Do feeds not leak out? We aren't decompressing babies on CPAP, so I'm curious. So again, so generally, gastric emptying time is about 1 to 2 hours. But generally what you can do is, safe is probably for 1 hour, you keep it clamped, and then the next 1 hour you can keep it vented. Even if last half an hour before the next feed also, even if you keep venting, that's good enough. Generally the milk doesn't come out, and that's why you raise it very high. So even if the milk comes up, it actually goes down. It doesn't come really out of the NG tube. So we have been safely doing it without much regurgitation. But yeah, if you do it immediately within first 10-15 minutes, probably the chance of regurgitations are higher. So maybe 1 hour or half an hour before the next feed is good. How much PEEP will lead to decrease preload? Okay, so that's a good question. Again, there are no studies backing up, but higher PEEP, so 7, 8 or 9, there are a few centers who practice PEEP of 8 or 10 or even 12. I have seen even use of PWP 12. Up to 8 or 10 also, many times we are comfortable. It doesn't really affect. The MAP generally on high frequency, generally the MAP of 16 or 18 is something which is very high. That can interfere with the preload. Generally CPAP up to 8 or 10 probably might be good enough. It doesn't really cause so much of rise in intrathoracic pressure. So because we often do echoes on these babies, and generally even CPAP of 8 or 10 don't show congested IVCs as we see on a high frequency, where even sometime 14 or 16 of MAP can give rise to the decrease in preload or congested IVC. So again, that's probably I would be very comfortable giving even higher PEEP without much worried about preload. What are the branded names for mustache types of covering? I will share the anyone has it? I can't remember off top of my head, but I might have a presentation where we had shown these images, which I'll pull up and I might put it in the group. So there are these the mustaches, they come up. I can't remember the name. So which you can cover the lips nicely. If anyone knows the name, cannulate. Correct, cannulate. That's the one. Cannulate is the one which very commonly used. Neosil is also someone has written. The cannulate is what we also use in our NICU.
Cannulate is easily available everywhere.
It's easily available, correct. So I think that's what even in Vadia we were using. It's very easily available and it's a very good, not very expensive also. Sridhar, PEEP level impact depends on compliance. Very rightly pointed. So because again we go up on the PEEP because the lung compliance is poor. So if you give high PEEP in a compliant lung, that can cause decreased preload. So that's why choosing the right PEEP is very important. So which is guided by your X-rays, your FiO2 recombinant, your chest rise and clinical sort of response. So I think that covers most of the points related to CPAP.